I'm, I'm Tiffany Carter. I'm the Perinatal Clinical Community Integration Manager with the VNPC. Thank you for joining us for the second part of this special 2SLGBTQIA plus learning series. If you missed part one, you can find it on the VNPC YouTube page, and I'll put a link in the chat for you to get that shortly. And I just have a few announcements before we get started. First, I'd like to remind everyone that we do host a regular monthly webinar series. It's usually on the second Tuesday of the month at noon. And you can register to join those webinars on our website. I'll make sure to put a link for that as well. And our next one will be next week, Tuesday, February 20th at 12 p.m. A couple more announcements. VNPC is hosting its annual Day of Learning on March 17th and 18th at the Westin in Richmond. Registration for the Day of Learning will be opening soon, but you can learn more about it now on our website, govnpc.org. Additionally, you can sign up for our newsletter there as well, and then that's a great way to stay up to date about our events as well as other information and updates from VNPC. And then lastly, I'll also share that the VNPC is launching our Community Care Advisory Committee. It's a part of one of 3 advisory committees, a part of our new governance structure, and we're still accepting interest forms for anyone that would like to work with the VNPC in that capacity. So if you're interested in learning more about that or submitting an interest form, you can feel free to contact me, and I will put my email in the chat for that. And now for our speaker today, I'd like to introduce Jess Bradley. They are the creator of Making Gaby, an online resource for queer and trans prospective parents. Their mission is to provide fertility and parenting information from a queer lens. Jess and their wife spent 7 years trying to conceive, during which they attempted several conception methods. Jess combined that life experience with extensive research on queer fertility to develop informative articles and online courses. In addition to queer family building, they have also presented on the topics of using a sperm donor and preparing for the journey of trying to conceive. Jess lives in North Carolina and enjoys cooking, rock climbing, and spending time with their family. Thank you for being here with us today, Jess, and I will turn it over to you.
Awesome. Thank you for the introduction, Tiffany, and thank you for having me here. I'm super stoked to be here. Actually just going to get a couple things arranged here. I'm going to share my screen, technology willing. Let's see. Okay, cool. All right. Looks like things are looking good on this end. Great. Okay. So, good day, everyone. Thank you all for joining me today for this presentation on queer fertility and family planning. As Tiffany said, my name is Jess Bradley. My pronouns are they, them, and I'm a queer and trans parent advocate. I created an organization called Making Gaby that focuses on providing family building and parenting information for the 2SLGBTQIA plus community. Before we jump into the subject matter, I always start with this disclaimer. I am not a doctor or medical professional. I am a parent who has done a lot of research about queer conception and family building. I recommend that any healthcare related questions about the information presented be directed to a doctor or medical professional. I also want to acknowledge that some queer people are in relationships where they can conceive sexually without fertility care or assisted reproduction. More power to those folks. That is fantastic. But this information focuses on people in the queer community who need some form of help with conception or family building. There are several ways that queer people can build their families, so we're going to cover a variety of topics today, and we're not going to dive too deep into any of them. You can consider this like a crash course in queer family building. We're going to start with a few different methods of conception, and then talk about gamete donation and trans fertility, and close out with adoption and parentage rights. So we've got a lot to cover. The first few methods of conception that we're going to cover are used by people with ovarian anatomy who want to conceive and carry a pregnancy. And in the queer community, that could be cis women, trans men, non-binary, intersex, or gender nonconforming folks. These methods all utilize a sperm donor, and we will get into some sperm donor terms as we go through them. All right, so we're going to get started with self-insemination. This method has many names: intracervical insemination, or ICI, or vaginal insemination. All of those terms describe sperm being placed inside a person's vagina. The ideal location is at the opening of the cervix. Some fertility clinics offer to do this procedure at the clinic, but most people do this at home, which is why it's also known as self-insemination or at-home insemination, or the somewhat outdated colloquial turkey baster method. It is, of course, not recommended to use a turkey baster. In fact, Virginia law specifies that a turkey baster is not considered medical technology, and using one for self-insemination could throw into question rights of parentage, and it did as recently as 2015. What does qualify as medical technology under Virginia law is a self-insemination kit. Sperm banks often ship sterile needleless syringes along with vials of sperm for this purpose, and they will also include paperwork from the sperm bank that clarifies that the donor has no parentage rights. If a known donor is being used, meaning someone known personally by the intended parent and able to provide fresh sperm, there are self-insemination kits available online, or the supplies can often be purchased at a pharmacy. And there are a few other supplies that people often use with self-insemination. Some of these are optional. A sterile specimen cup if a known donor is being used, a disposable menstrual cup for after depositing the sperm to help it stay inside, and also latex gloves or similar, especially if a sperm bank is being used, because the vials will likely be stored in a nitrogen tank and the gloves are needed for skin protection when retrieving a vial from the tank. I am not going to go into more detail about the specific process of self-insemination in this presentation, but for anyone interested, I published a blog post with several tips, and I'll drop a site link and also some book recommendations at the end of the presentation. So next, we're going to talk about who chooses self-insemination. ICI is a great method to try when there are no known fertility issues. It is the least expensive conception option, so a lot of people are drawn to it for that reason, especially those who do not have health insurance that will cover fertility care, or for people who want to try self-insemination before going the route of fertility care. The success rates for self-insemination fall into a really wide range. The ballpark is between 5 and 30% for each cycle attempt, but success rates go up significantly over the course of 6 attempts, and ideally those would be consecutive attempts. One of the keys to success with self-insemination is properly timing the insemination around ovulation. If you are a healthcare provider and your patient is choosing this route, a great way to support them is by encouraging them to track ovulation and use that as a guide for timing inseminations. It's ideal to track ovulation for a few months before attempting conception, so the intended parent or parents have that data as a guide for the ideal timing. Another significant point is that fresh sperm has a higher rate of conception with ICI than frozen sperm. So if a known donor is being used, that's another plus for trying self-insemination. But I have to add that although that data is out there, it doesn't mean that frozen sperm doesn't work with self-insemination. Many babies have been conceived using ICI and frozen sperm, but it's just worthwhile to point out that data. If someone is using frozen sperm from a sperm bank with self-insemination, the conception attempt has a higher chance of success when that sperm sample is unwashed. Unwashed sperm means raw semen. The sperm banks will specify whether a vial of sperm is washed or unwashed. On the other hand, washed sperm has been processed to remove dead sperm cells and cellular debris, and is a more concentrated semen-less sperm sample. Wash sperm is required for the next methods of conception that we'll cover, which is a great segue to the next topic, IUI. So IUI stands for intrauterine insemination. This is a procedure where sperm is placed directly into a person's uterus. It is done through a uterine catheter, which is a sterile flexible tube. And as I just mentioned, only washed sperm is used for this procedure. The tip of the catheter is inserted into the intended birth parent's cervix, and the sperm is injected through the catheter into the uterus. Unlike self-insemination, IUI is not safe to do without proper training and medical knowledge. So who does offer IUI services? Intrauterine insemination is often performed at fertility clinics by an OBGYN or a reproductive endocrinologist. In some states, midwives can also offer IUI services, but in most states, it's a legal gray area. So the best way to find out whether it's possible is by checking in with the local midwife community. There are two different kinds of IUI, unmedicated and medicated. An unmedicated IUI refers to an IUI process that does not involve fertility medications, as the name implies, but rather relies on ovulation tracking to select the desired timing. This is more common with midwife preconception care. Fertility clinics will often recommend a medicated IUI, which involves taking hormones prior to the IUI procedure that will initiate ovulation. And clinics have varying recommendations, but the top three fertility drugs prescribed in combination with IUIs are Clomid, letrozole, and GSH. So Clomid is an oral medicine taken for several days prior to ovulation, and it causes ovulation in people who often do not ovulate. Letrozole is an alternative to Clomid. It's often used when Clomid is not effective before moving to GSH, which is an injectable. And leading us to GSH, it is also known as injectable gonadotropin. It's also known as a trigger shot. It is a more aggressive fertility treatment. It is known to have a higher success rate than Clomid and letrozole. All three of those fertility medications have the potential to cause multiple eggs to be released in one cycle, which could result in multiple pregnancies. And they all have some potentially unpleasant side effects, but for people who experience fertility challenges, they may be the best option. Touching on success rates, for IUI, the ballpark is still wide, 5% to 20% per attempt. The chance of success decreases as a person gets older, and there's varying data on this, but studies in general show a slight drop in success starting in someone's late 30s and a larger drop in success once the intended parent is over the age of 43. Most people who are in their early 40s will be recommended for IVF, which we will cover next. So why do people choose IUI? There are different reasons why people pick IUI as their conception method. If the intended parent wants to do fertility treatments, IUI is often the place to start, even if they're actually more interested in IVF. And that's because some insurance policies will only cover IVF after a certain number of IUI cycles have been attempted, and that number is often 6. Another reason that people choose IUI is if they have tried self-insemination for multiple cycles without success. There is data that shows that IUI has a higher rate of conception than self-insemination when using frozen sperm. And lastly, IUI may be recommended by a healthcare practitioner for someone with specific fertility challenges, especially around ovulation. Regarding the timing of the IUI procedure, kind of as mentioned before, working with a fertility clinic, the clinic will work with the intended parent to plan the timing of insemination and the associated fertility treatments. For unmedicated IUIs, tracking ovulation to properly time the conception attempt is totally key. And that's it for intrauterine insemination. So now we are going to move on to in vitro fertilization. IVF is the process of retrieving eggs from a person's ovaries and fertilizing them with sperm in a lab. It is done in combination with hormone treatments to produce as many viable embryos as possible. And there are multiple types of IVF treatment. We're going to start by describing the most common IVF process. The first step is ovarian stimulation, often using the same fertility drugs mentioned along with IUI. These medicines will cause more eggs to be produced than is typical during a normal cycle, which is usually just one. While these medicines are being taken, blood tests are performed to monitor changing hormone levels, and ultrasounds are used to confirm that the eggs are indeed maturing. And the next step is ovum retrieval, or egg retrieval, which occurs through a process called follicular aspiration or transvaginal ultrasound aspiration, which is a minor surgery. After that, the eggs are fertilized in a lab using wash sperm, which could either be sperm from a sperm bank, or if a known donor is being used, the lab can likely wash the sperm sample, and they may also perform a semen analysis for motility and sperm count before fertilization. The most common fertilization method is just to mix together the sperm and eggs in a controlled environment. And the next step is embryo growth. The fertilized eggs begin cellular division and are grown in a culture medium for a few days. If genetic testing is desired, this is the stage where that takes place. And the final step of IVF is the embryo transfer, where one or more embryos would be transferred into the uterus of the intended birth parent. If all goes well, the embryos will implant and the person is pregnant. So regarding who uses IVF, anyone with ovarian anatomy could be a good candidate for IVF if they fall into one of the following groups. If they are over the age of 40, if they have known fertility challenges, if they've been trying to conceive through ICI or especially IUI for 6 to 12 cycles consecutively and have not had a successful conception, or if they want to store embryos for a future pregnancy, which could include trans men or trans masc individuals who are taking or considering HRT. A couple other groups that also use IVF are surrogates or gestational carriers, which we'll cover in just a few moments, or people who are interested in reciprocal IVF. So reciprocal IVF is another kind of IVF, and it's an option for couples where both partners have ovarian anatomy. It's a process where one partner's eggs are harvested and fertilized and then implanted into the other partner's uterus. So one partner is the egg donor and the other is the gestational or pregnant partner. If the goal is to have the entire process take place on the same cycle, then the partner's monthly menstrual cycles are aligned with fertility medication and fresh embryos are implanted. But frozen embryos can also be used for future transfers. So to close out the overview of methods of conception, we're going to take a look at the general cost of each of the methods that we've just reviewed. For self-insemination, if the sperm is being purchased from a sperm bank, the cost is approximately $1,500 per vial, plus shipping and storage costs as needed, which could add a few $100s to each shipment. Some people choose to do multiple inseminations in 1 month to increase their chances of success. The cost of IUI varies quite a lot. It is between $300 on the low end and up to $4,000 out of pocket. The range is so big partially because of the different options with IUI, like where the procedure is done and what medications are or are not included. Insurance may cover some cost, and those cost estimates do not include purchasing sperm. Traditional IVF costs will range from $10,000 to $25,000 per cycle. And it's possible that insurance will cover some of that depending on someone's policy. And reciprocal IVF costs are often $20,000 or more, depending on which specific procedures and fertility treatments are used. So now that we have covered the most common methods of conception that queer people use to build their families, and along with that, we've discussed some aspects of sperm donation, it's time to talk about egg donation and surrogacy. And we're going to start with egg donation. An egg donor is a person who has ovarian anatomy who is willing to donate their eggs to an intended parent or parents. People who are seeking egg donors either do not have those gametes or have no desire to supply them for conception. And in the queer community, that could be cis men or trans folks or cis women and people who are assigned female at birth who experience fertility challenges. Depending on the situation, the intended parent may also be seeking a gestational surrogate, or they may be willing and able to carry the pregnancy, but just not supply the egg. Regarding the egg donation procedure, it's basically the first two parts of a full IVF cycle: ovarian stimulation and egg retrieval. The eggs can be immediately frozen to be fertilized at a later date, or the fresh eggs can be taken through the entire IVF cycle, meaning they would be fertilized with sperm, the embryos would be grown and then transferred to a surrogate. But the most common procedure is that the fresh eggs are fertilized and then the resulting embryos are frozen for transfer at a later date. Donors are usually found through egg donor banks, and sometimes surrogacy agencies will also offer egg donation. If an intended parent is interested in egg donation, it's important for them to research fertility clinics that specialize in working with egg donors, because not all clinics do. The cost of egg donation averages around $50,000, and that includes the IVF procedures that are involved. And now we're going to pivot to specifically talking about surrogacy. A surrogate is a person who is willing to carry a pregnancy for an intended parent or parents. And there are two kinds of surrogates: traditional and gestational. Traditional surrogates are people with ovarian anatomy who donate their eggs and also carry the pregnancy, so they are biologically related to the child. The conception process with traditional surrogates can involve IUI or IVF. Traditional surrogacy is not allowed in all states in the US, but it is legal in Virginia. However, it is less common than gestational surrogacy. So gestational surrogates are people willing to carry a pregnancy for intended parents but not supply the egg. The pregnancy method used for gestational surrogacy is always IVF. For gestational surrogacy, a separate egg donor goes through the egg retrieval, and then after the egg is fertilized and the embryos are grown, the surrogate goes through the embryo transfer to hopefully become pregnant. The cost of surrogacy can range from a little over $100,000 to $200,000, depending on the type of surrogacy and specific situation. And that includes substantial medical costs like IVF, prenatal care, birth, postnatal care, in addition to compensation for the surrogate. And we will actually circle back to a few more points about using a surrogate when we cover adoption and legality. But our next topic is transfertility. The transfertility information that we'll cover centers around people who are considering or already utilizing gender-affirming care, meaning surgery and/or hormones, in order to medically transition. Some trans people choose not to or are not able to medically transition, and that does not make them any less trans. But this information focuses on fertility and gamete preservation options for those who do choose to medically transition, at least to some extent. So we're going to start with ladies first: options for trans women, trans femmes, or anyone who is born with testicular anatomy. Regarding HRT, if a sperm-producing person takes estrogen, that can affect their sperm count and motility, but exactly how much fertility is affected really depends on the dose of estrogen and the individual's reaction. This is also the case with anti-androgens, which block the production of testosterone. Androgen blockers are often prescribed to trans women along with estrogen as part of their HRT regimen. A study on the effects of HRT revealed that many people recover fertility once hormone treatments have been paused for a number of months, but this is not the case for everyone. So overall, it is ideal to go through fertility treatments or gamete preservation before beginning HRT. Another practice that impacts fertility for trans women and trans femmes is tucking. The process of tucking increases the temperature of the scrotum, which negatively affects sperm production. However, sperm counts tend to resume at typical levels if someone stops tucking for a few months. The gender-affirming surgery that affects fertility for trans women is an orchiectomy, which is removing the testicles. Once that surgery has been performed, the person's body will no longer produce sperm. So if they want to preserve the option of becoming a biological parent, they can freeze and store sperm before undergoing that procedure. There's also the possibility of extracting sperm for storage as a part of the orchiectomy. So that leads us to talking about gamete preservation. People with testicular anatomy, often assigned male at birth, have the option of working with a sperm bank to freeze and store their sperm. The cost of sperm storage through a sperm bank is approximately $1,000 per vial for the first year, with storage costs reducing per year for longer terms. Gamete preservation is often paid for out of pocket. For someone who stores sperm, the plan would be that in the future, they could use some combination of an egg donor and a surrogate to conceive and carry a pregnancy, or they may have a future partner who has the ability and desire to carry a pregnancy. But either way, a pregnancy could be created through any of the methods of conception that we've covered. And another one that I'll mention now, a specific kind of IVF called intracytoplasmic sperm injection, or ICSI, or sometimes it's called ICSI. That procedure involves injecting one sperm cell directly into an egg, and it could be a good assisted conception option for people who have low sperm counts or motility due to beginning HRT before gamete preservation. So now we're going to shift to fertility options for trans men, trans mascs, or people born with ovarian anatomy. When it comes to HRT, taking testosterone at certain levels for a prolonged period of time will cause ovulation and menstrual cycles to cease, but pausing testosterone can allow these cycles to resume, although again, everyone's reaction is different. There are numerous examples of trans men or trans masc individuals who pause HRT in order to carry a pregnancy. And there are fertility clinics and midwives that specialize in working with trans folks. The gender-affirming surgery that would make a trans man unable to carry a pregnancy is a hysterectomy, which is removing the uterus and sometimes includes removing ovaries and fallopian tubes. Many trans men do not get the surgery, but it's the most significant one to mention regarding this topic. For people who are assigned female at birth, gamete storage is more expensive and more complicated compared to folks who are assigned male at birth. A person with ovarian anatomy can go through egg retrieval and then have those eggs frozen for future use. They could also consider going through IVF, or at least some parts of IVF, to not only retrieve the eggs, but have them fertilized, and grow the resulting embryos in a fertility lab, and store the embryos for transfer at a later date. The average cost of egg retrieval is about $15,000 per cycle, and some people will opt for multiple cycles. And the storage costs for eggs is approximately $500 per year. In general, insurance does not fully cover elective egg freezing, but it really just depends on the specific policy. One other important factor related to this topic is gender dysphoria. Needing to pause or delay medical transition or going through fertility treatments may cause some trans people to experience severe gender dysphoria. And for this reason, some trans folks will decide not to pursue biological parenthood. But If you're a healthcare practitioner with a patient who is trans, it's good to be aware that gender dysphoria could be a factor, and the person may want to utilize emotional or mental health resources and support. Okay, we've covered a lot of information and we're down to our last topic here, which is adoption and legality. A lot of queer people build their families by becoming adoptive parents. The two most common adoption options in the US are public and private adoption. Public adoption is available through state-run agencies and is often a much lower cost than private adoption. Queer people in the US have not always been able to legally adopt, but what turned the tide on this on a national level was the legalization of gay marriage. In one sense, it solidified the right of queer married couples to adopt. However, adoption is regulated on the state level, and many states have passed religious exemption clauses that permit agencies to discriminate against supporting or aiding adoption if it conflicts with their religious beliefs. And Virginia is one of those states. So even though the rights of queer people, even though the rights of queer married couples specifically to adopt was made clear by the state, discrimination is still allowed under something called the Conscience Clause, and there are no explicit protections against discrimination around adoption based on sexual orientation or gender identity. So it's really important for people interested in adoption to work with a queer-friendly agency. There is another kind of adoption that is very relevant to queer couples, which is step-parent adoption. That kind of adoption is needed mostly for families when one parent of the child is a biological parent and there's a non-biological parent who wants to gain full parental rights. And step-parent adoption is legal for married couples in Virginia. It's easier if there's only one legal parent going into the process. It is still possible if there are multiple parents, but it is legally more complicated. Another important point around this topic is that even if both parents are on the birth certificate, step-parent adoption is needed for fully establishing legal parentage rights. The next aspect to cover around parental rights is donor agreements for sperm and egg donors. This is most applicable for known donors and can be drawn up by a lawyer to establish who the intended parents are and explicitly state that the donor is not an intended parent. There are also non-donor agreements for known donors who want to co-parent. The important thing is to work it out either way with a lawyer ahead of time so that parentage rights would not be questioned in the future. Regarding surrogacy agreements, pre-birth orders are used in some states, but they're not recognized in Virginia. And there is technically a prior court process available, but it's really intensive and almost all surrogate arrangements don't go through that process, and they rather rely on a post-birth order and something called a declaration of parentage. As I mentioned earlier, both kinds of surrogacy, gestational and traditional, are legal in Virginia, but per state law, a traditional or genetic surrogate can nullify the contract and keep the child. So for that reason, gestational surrogacy is strongly recommended. Surrogacy is most often handled through an agency, and a good agency will help intended parents get access to proper legal counsel and work through questions and agreements as much as possible ahead of time. The adoption process for traditional surrogates, as one could imagine, is more complex than adopting a child who is carried by a gestational surrogate. So this concludes our presentation on queer family building. For more resources, or if you want to look into this information further, please check out the site makinggaby.com. And there are a lot of resources there. And I also just listed a couple of recently published books that are written by midwives that are both specifically about queer conception. And I'm open for questions.
Thank you, Jess. I don't see any questions in the Q&A. Does anyone have questions that they'd like to submit at this time? And in the meantime, I had just a couple. One was, are there any general safety considerations that you're aware of that intended parents should consider as they start their journey?
Intended safety considerations. I
Yeah.
mean,
And that could be like health wise or just in general, like is there a scam element that could be possible as they're
yeah,
looking into their options and
right. Um, yes, there are. I mean, there's like a few different levels of this. I mean, the one that's a lot of people will just say like, okay, yeah, that makes sense, is obviously somebody who wants to carry a pregnancy or wants to become a parent, biological parent themselves, and carry a pregnancy. It's good to work with a doctor or medical care practitioner to, get some tests. It's good to be tested for CMV status and things like that before going through the process of selecting a donor. Excuse me, and even testing for blood type. And take a sip of water here. I would say though that also little bit buyer beware on fertility industry and different sperm banks. It's really good to do research on sperm banks, certainly surrogacy agencies as well. But there are a lot of sperm banks in the US. That side of the fertility industry is very scarcely regulated. And so there are a few different things to be aware of when doing research on through those sperm banks. One of them would be to look at what the family cap limit is for donors. There is no specific regulation nationally by the US. Some other countries have imposed regulation, but each bank just kind of sets their own family cap for donors, and some of them are very high, and then some of them by comparison are very low. So I'll give you an example. One could be 10 and the other could be 100. And that is a really big difference with implications of how your child may feel about it many years later. So that's just something to
and
be aware of.
could you just quickly explain what you mean by family cap?
Yeah. So what I mean by family cap is, yeah. So if a donor, donates sperm and then it is sold to intended parents and conception is successful and a child results from that pregnancy, that usually what happens, what intended parents are always asked to do is communicate with the sperm bank, that their conception was successful, that their pregnancy was successful, and now they have a hopefully healthy child. So the sperm bank will take a note and basically note that that donor has a child with that family. They usually are pretty pretty lenient on providing more sperm to those same intended parents if those intended parents want to have a sibling that is related to that sperm donor. So that's easier. But the other thing is that what I mean by the cap is that how many other families are allowed to also use that donor. So if the cap is really, really high and it's 100, then that means that there could be 100 families who have that same sperm donor. And there are a lot of people who are now donor conceived adults. There's a big donor conceived advocacy community, which is really cool now, that's coming up because so many people who are donor conceived are becoming adults and have their own opinions about this, that they're concerned about things like accidental incest if
Mhm.
those family caps are really high. So something to keep in mind.
I see. That makes sense. Thank you. And then another question I was going to ask is, how available is care and resources and support um, for all of these fertility options that you just told us about? Because it kind of seems like it might be slim to find a place that is queer friendly or that will give you honest truth if you're looking for it, but I'm not sure. So I'm asking if you might know, how available is that?
Yeah, I mean, I think part of it really depends on where the intended parent is located. Honestly, because there are some states where midwives don't have a lot of options, for instance, for preconception care, and the laws around even self-insemination can be pretty tight, like things like, you have to use a self-insemination kit and you have to make sure that you have the paperwork signed ahead of time to make sure that there's no parental rights coming into question in the future. So some of those states, I think intended parents in those states need to be really aware of, what the legality is, and just aware of their options. There are some states, because midwives cannot offer preconception care, meaning they cannot perform IUIs legally, where the intended parent's only option is either at-home insemination or the fertility care route. And then there are other states where the midwife community is really vibrant and strong, and there are a lot more options for those parents. And there's a little, it's a little bit easier to even do self-insemination and sign somewhat of a more simple agreement to state who the intended parents are and not be concerned down the road about potential legal implications.
Thank you. Well, thank you so much again for your presentation. I know that I learned a lot, and I appreciate you being here with us today. This is going to end our webinar, folks. So thank you for joining us. Remember, our monthly webinars are the second Tuesdays of the month, and we will continue with this special series. And the next one will be, I am so sorry, it is the fourth Thursday of next month. But if you missed part one, you can see that on our YouTube page, as well as this one will be posted on our YouTube page. So please, if you haven't registered, please go to our website, govnpc.org, to register for our upcoming webinars. Thank you and have a great day.
Thanks, everyone.